This is Chadi Alraies from NCVH 2025. I'm really privileged to be with Dr. Tom Davis to talk about new options and therapies for patients with advanced peripheral artery disease. Dr. Davis, thanks for being with us.
Oh, my pleasure.
So tell us about this new technology or new approved technology as well as technique, and who is a candidate for it?
Okay, so what the new technique is where we come down and there's really no vessels below the knee that are going to the foot, and it's for those people who have critical limb ischemia and wounds or rest pain. And what we do is, since we can't get an adequate blood supply down to the foot, we have a procedure where we hook the posterior tibial artery to the posterior tibial vein, and that brings arterialized blood down through the venous system, and it acts like, it eventually becomes like an arterial conduit to the foot.
So who's the patient who are qualified for this technique?
So really it's no option patients, the ones that don't have an option for angioplasty, or patients who don't have a bypass option for the leg, and who are at risk of limb loss.
And this technique can be done in any certain labs, or any certain stent has to be used?
Well, right now people do it off-label, but there's an approved device that actually it's called LimFlow, and so they have the proprietary stents and also the actuator that has a needle that goes into the vein, and we can remove and pass a wire down into the vein. So, and plus the other thing that we have to do, because the valves in the veins have to be destroyed, they have a valvulotomy thing that scores the valves in the veins. So, because if we didn't do that, the blood would never get down to the foot. The valves would hold it up.
So what I'm understanding is you have an inflow and outflow, and the inflow from artery to vein, and then from vein to artery.
Yes.
Is it easy, and what device you usually use to cross from A to V, and how to come back?
Well, again, they have a proprietary device itself, and what it is we have to access the artery from top, and we have a wire down into the origin of the posterior tibial artery, because that's not open all the way down, or perineal we can use too as well. And then what we do is we come from the bottom of the foot in the lateral plantar vein, and then come up the vein, and so we marry the two up next to each other, and then we have a device that has a needle that we can pop out, and there's a receiver in the vein, and so the wire comes into the receiver, and then we can pull everything down. So now we have a wire from the femoral access in the artery down to the plantar vein in the foot, and then we can work over that up and down.
Really, yeah. Flossing, almost flossing.
Yeah, exactly. It's a flossing, and then we can put our stents and open everything up.
And the sheath size for delivery of the stent?
It's a 7 French.
7 French. So it has to be deployed from the femoral artery, most likely.
Yeah, it's because the devices are the length that they are. We need to come and antegrade access in the femoral artery, or antegrade in the SFA, depending who it is. So those are that's the one thing that we have to be able to do.
Absolutely.
And some patients there's much more difficult access sites there, but typically that's how it works. The procedure itself takes a while for it to mature. I use that term because patients tend to get a little bit worse before they get better, because that arterial blood going into the venous system, they can get some swelling, they can get a little pain because they have some steel. So the procedure itself doesn't end as soon as the patient leaves the table. Sometimes we have to do other different types of procedures, such as coiling of veins that can steal, because you can imagine in the foot, as you're coming down the posterior tibial vein into the lateral plantar vein, there's branches that come up to the SSV and the greater saphenous vein, and you want that blood to get out to the loop, a venous loop out to the first metatarsal perforator, because that's where you got to get the blood. But if the flow is so much that it goes right back up the veins,
you have to.
So then sometimes we'll have to, if there's too much flow going down there, we'll have to go in and coil off those veins so you can divert the blood. You want to divert it out to the foot, exactly.
Final question, management after, like anticoagulation or antiplatelet is enough?
Antiplatelet, we use aspirin, Plavix, typically, and unless they have a need for, a DOAC for whatever reason, but it's dual either way. And then we do have to get frequent Dopplers on them, because we measure the flow. And so at 2 weeks we'll get a Doppler flow volume, because that's how we measure if there's any steel going on. So if the flow is too high, then we know we got to do something to some of the other veins. If the flow starts going sluggish, then we know there may be a problem with the inflow of the graft, and so then we need to go in there and try to fix that, because many times we'll end up putting drug-coated stents or DESs in the origin of the posterior tibial just before the stent grafts.
Absolutely. Well, thank you so much again, Dr. Davis, for very enlightening. Again, this procedure has been done before, but now it's become more kind of and specialized centers for patients with disparate, with advanced, and no option with PAD. Thank you for watching us. This is Chadi Alraies coming to you from NCVH 2025 and your news. Dr. Davis, thanks again.
Thank you.
Awesome. Thank you.